everyone. Many different parts of the world, I know. Thank you for your attention and interest today. Today, we're very fortunate to have Dr. Lauren Heptinstall, who's a consultant renal pathologist at Cambridge Hospital. She's previously trained at the Royal Free in London, previously worked at UCL, and has been consultant renal pathologist in Cambridge now for the last 2 years. Renal pathology is one of those things I think you can't, an introduction to renal pathology can't be emphasized enough. It's a difficult area. I know that people's experience of it and use of it will be very varied in different territories. So it's always, as a hemopath person, I always think it's always very good to go back to basics and be reminded of the basics, particularly from someone who's an expert in the field, and obviously operating at a very high level in a very complex department, because I know from my own experience that everyone always goes back to the basics. So an introduction to renal pathology, I think, is a very appropriate subject. And so without further ado, I will pass over to Dr. Heptinstall and start the recording. Thank you. Over to you, Lauren. Thank you.
Thank you for that kind introduction. And hello, everyone. It's a real pleasure to be here. So I'll run through an introduction to renal pathology today. I'll just be focusing on native, and I will focus on glomeruli because that's what people tend to find most tricky. Please do put any questions in the chat, and I'll do my best to have a bit of time for questions at the end. So this is the outline of what I'll do today. So a little bit on tissue handling. Most of the time will be spent on the approach, and then I've got just 2 example cases at the end. Okay, so tissue handling first of all. So as I'm sure you all know, we tend to take cores of tissue from the kidney, and the first thing we do when we receive them is we have a look at them macroscopically. So under a very low power microscope, you can have a look at the cores and decide whether or not you think you've got renal tissue or not. Generally, the people who do the biopsies, whether that is nephrologists or radiologists, are really, really good at this, and it's not generally a problem. But we do want to check, do we think we've got kidney? And these 2 cores are showing us what that generally looks like. And do we think we have cortex or medulla or a mix of the 2? And this is what cortex generally looks like, mostly sort of a tan colour with these little dark red blobs in it. And these red blobs are the glomeruli. So that's what we're looking for to know that we've got some cortex. And this is what medulla looks like. So tan, but with lots of little red streaks in it. And those are just the vasa recta that we're picking up there, but no sort of blobs to indicate glomeruli. Once you've decided that you've got renal tissue, you can decide what to do with it, how many samples you need. So we need something to process into paraffin for the light microscopy. If your lab does immunofluorescence, then you would need to cut a piece off, including glomeruli, for immunofluorescence, and that will be frozen. And if you're doing electron microscopy, then a piece of the cortex would also need to be cut off for that, and put in glutaraldehyde. So there's a few decisions to be made at that point as to what you do with the tissue you've received, depending on what your lab is going to do with it. And also there's a decision on urgency. Obviously, lots of these biopsies that we get are considered urgent, so they need processing rapidly. Okay, and then what do we do when we've got our wax block? We do a few different stains, and I'll just run you through those quickly. So we do the classic hematoxylin and niacin H&E stain, and obviously that just gives us a really good overview of the tissue. So we can see the glomeruli, we can see the proximal tubules, we can see the interstitium, we can see the peritubular capillaries, all nice and clearly. So that's good for just your overall assessment of what you think is going on in the kidney. Then we have the PAS, the periodic acid shift stain, and this is particularly useful for looking at things like the basement membranes and the mesangial matrix. Also, if you have any vascular hyaline deposits, it's also really useful for that. So it's useful for things like looking at the cellularity of glomeruli, if you think that may be increased, if you think there's any changes in the mesangial matrix, and if you think there are vascular changes. So this is an example of the PAS stain, and this is quite a cellular glomerulus. And because we're looking at this stain, we can see the mesangium nice and clearly. It's this dark pink area and the nuclei stand out as pale blue. So we can count the nuclei in there and see that there's lots of them. So this is an example of mesangial hypercellularity. So that's the PAS stain. Then we have the silver stain. Again, this is particularly useful for basement membranes, also shows you the mesangial matrix quite well, and any areas of fibrosis. So if there's scarring in the kidney, if there are areas of chronic damage, it's really useful for that. It shows it nice and clearly. So this is really good for looking at capillary walls. So you can see they look really nice in this particular glomerulus, which is normal. They look nice and crisp. I can't see any thickening. I can't see any abnormalities, no reduplications. I can't see any spikes. Those are the sorts of things that we look for on capillary walls. Also the matrix. So the mesangial areas have this collagenous matrix that we look at. And because that stains so darkly on the silver stain, we can see how much of that there is. So if it's increased, we'll be able to pick that up on the silver stain. Here it looks normal. And the degree of chronic damage in the kidney overall. So we're looking at sort of the amount of tubular atrophy and interstitial fibrosis. It's nice and easy to see on the silver. Okay, then the Congo red. As in any part of the body, this is useful for amyloidosis. And this is an example of amyloidosis in the kidney. You can see that this is a glomerulus here, and there's lots of this pale salmon pink deposition here, which is the amyloid. It's also outside in the small vessels. And this is another glomerulus here. Just a hint in a vessel wall there as well. And for confirmation, we look at it under polarized light, and it gives us this birefringence with this greenish color to it, and that confirms that we're looking at amyloid. Just to say that this only works if you're looking at a Congo red stain. It doesn't work on any other stain, because I know some people do get confused about that. So the principal reason we do a Congo red is to look for amyloid, but it's also useful for a few other things. Eosinophils stain up really nicely. So you may see lots of those in a case of tubular interstitial nephritis, for example. Also calcium phosphate deposits stain nicely, and we can see an example there. That purplish crystalline deposit there is calcium phosphate. A common finding to see in a kidney, particularly in someone who's got a bit of scarring. So it's not particularly clinically significant in the vast majority of cases, but if you're wondering what it is, it can help you to make that decision. And elastin in vessels, it does stain that. So the main reason to know that is so that you're not confusing normal elastin with vascular amyloid deposition. Okay, and our last sort of light microscopic stain that we do is a connective tissue stain, for example, a hematoxylin Van Giesen, a HVG, and this helps you to look at the connective tissue, so areas of interstitial fibrosis will stand out, and elastin in vessels. So if you're looking at vessels and they show some chronic vasculopathy, often hypertension related, that'll stand out nicely on the elastin stain. Okay, so those are our usual light microscopy stains. The next thing we do is some form of immunostaining. So different labs do different things. There's an option of two. You can either do immunohistology or you can do immunofluorescence. This is an example of immunohistology at the top here, and this one underneath is immunofluorescence. There are advantages and disadvantages to both. The key advantage of immunohistology, the top one, is it can be done, it can be assessed under your normal microscope at your desk, whereas immunofluorescence requires a fluorescing microscope. Immunohistology also can be done from a slide from your wax block, whereas immunofluorescence requires a separate piece of frozen tissue. So it depends what you've got access to, but this would require a bit more tissue. Also, immunohistology will last longer. You've got the slide to keep, whereas immunofluorescence will not last. You'll have to take photos and keep those. However, immunofluorescence is more sensitive and more specific, so it's generally easier to interpret. So it just depends what you've got access to. A very few labs will do both. Our lab does immunohistology. So we generally do all of these different components, whichever methodology you're using. So we do immunoglobulins G, A, and M. We do complement components C1q and C3, and we do Kaplan Lambda light chains. And if you have access, electron microscopy can be very useful. It's recommended to do electron microscopy in pretty much, well, in every native renal biopsy and the vast majority of transplant biopsies now, but obviously it depends on access. Often it will confirm what you already think. For example, if you had a case of IgA nephropathy, which this is an example of, it will show you electron dense deposits, which is what we've got, these sort of darker areas in the mesangium here. So it helps to confirm what you already know. However, there are particular diagnoses where it's either essential or very, very helpful. And those are generally the ones where there are glomerular basement membrane changes. So things like Allport's disease, collagen 4 changes, thin basement membrane disease, those it would be either very, very difficult or impossible to suggest it without access to electron microscopy. Also, other things like podocyte changes can be much, much easier to see on the electron microscopy just because you're looking so much closer. And other structures, for example, in cases of lupus, tubulo-reticular inclusions in endothelial cells will be visible on electron microscopy. So that sort of thing, if there's not a known diagnosis of lupus, could help point you in the right direction. So it can be very, very useful. Occasionally it's essential. So those are the things that we do with the tissue, and I'll now run through the approach to a renal biopsy, and this will take up most of the talk. Okay, so clinical history is really essential in renal pathology. Demographics are useful, age, sex, ethnicity, all of these change what will be in your differential. The indication for the biopsy, generally there are 5 different ways that people present with renal problems. They either have the nephrotic syndrome, they have acute kidney injury, AKI, they have chronic kidney disease, CKD, or they have isolated hematuria, or they have isolated proteinuria. And you should be able to put a biopsy into one of those categories according to the information that you're given. If there are any previous biopsies, it's really useful to know what they show so that you can comment on what you currently see and how that differs from the previous biopsy. Any available test results, so if a renal screen has been done, which it should have been, what are the results if available? For example, any known autoantibodies would be really useful, ANCA serology, all that sort of stuff ideally would be available. And then the clinical question is also important because you're writing a report to aid the clinician treat the patient most appropriately. So it's important you know what they want from you. So is it just the diagnosis? Is that what they need? Do they think there's vasculitis and they want you to say yes or no? Does the patient have CKD and they want to know why? Do they know that the diagnosis is lupus and they need to know how active it is? So there's a slight nuance to it, and it's important that we know what exactly is needed from us when they give us a renal biopsy so that we can do the report in the most appropriate and helpful way. Okay, so the clinical presentation, as I said, there are 5 different options. The nephrotic syndrome is a frequent one. And there are 6 different main differentials that we can pick up using the renal biopsy when someone has the nephrotic syndrome. And those are membranous glomerulopathy, FSGS, focal segmental glomerulosclerosis, minimal change nephropathy, diabetic nephropathy, amyloidosis, or lupus nephritis. So, I mean, almost all renal biopsies with the nephrotic syndrome will have one of those diagnoses. AKI, acute kidney injury, has a very wide differential diagnosis. Generally, we should be seeing the intrarenal causes. The pre-renal causes should be treated and picked up clinically. The changes on a renal biopsy for all of these sorts of things like hypovolemia and sepsis will be very non-specific. Generally, they'd have an appearance of acute tubular injury, and you wouldn't be able to say what the underlying cause was. So a renal biopsy is not very helpful in pre-renal causes generally. Post-renal causes, again, it can be quite non-specific on the renal biopsy. And imaging and clinical features are often more helpful and more specific than the renal biopsy, although sometimes it can be helpful. So things like obstruction and reflux, chronic pyelonephritis, those sorts of things. Occasionally we get biopsies for those, but generally we don't. So these are the sorts of things that we're generally considering when we get a renal biopsy with an AKI presentation. So acute tubular injury, tubular interstitial nephritis, cast nephropathy, vasculitis, thrombotic microangiopathy, post-infectious glomerulonephritis or infection-associated glomerulonephritis, and Henoch-Schönlein nephritis, a form of IgA nephropathy. So those are our main differentials for AKI. CKD, chronic kidney disease. We do sometimes get biopsies for these, and sometimes it's very difficult to say what the underlying cause was, or it can be probably a mixture of things. But occasionally we can say with certainty that there is a specific diagnosis, and these are the common ones. So diabetic nephropathy is a common cause of CKD. Also hypertension, so hypertensive nephrosclerosis is a common one. Renovascular disease, very similar. Reflux nephropathy. ADPKD, so polycystic kidney disease, we don't generally get biopsies for these, and the diagnosis is usually known, so we very rarely get biopsies for that. But it's important to know that any chronic glomerulopathy, like IgA, like FSGS, like lupus, all of these, if not successfully treated, will eventually present with CKD. It may be that this is the initial presentation and it's just not been picked up until that point. So any chronic GN is a possibility in a patient with CKD. Isolated hematuria, the differential is much more limited. IgA would be the commonest one. Thin basement membrane disease, particularly in patients who have a family history, would be one. Lupus nephritis can present in this way, although it's uncommon we get a renal biopsy in these patients. Often they're not biopsied unless the disease is more active. And also Alport syndrome can present with hematuria. And proteinuria without any AKI or CKD, again, has a much more limited differential, and it's more unusual to receive these biopsies, but the differential would be FSGS, diabetes, again, lupus, and Alports. Okay, so I'll now run through what we see on the biopsy. So a bit of normal histology, first of all. So this is what normal cortex looks like on H&E stain. We have our glomeruli, which I'll talk a bit more about in a minute, and the vast majority of the cortex is made up of proximal tubules, which are these tubules with these tall cells with lots and lots of apical, very eosinophilic cytoplasm. We also have some distal tubules, which are these more cuboidal ones with sort of darker, denser nuclei. The vessels are generally inconspicuous. They are the peritubular capillaries, these little ones here. And you will see occasional arteries. There's a small one just at the edge there, and veins and lymphatics as well. So that's the cortex. The medulla, it's just full of tubules and the vasorector, really. So we have lots of parts of the loops of Henle, which are quite difficult to differentiate from one another without special stains. We have collecting ducts, which are these sort of cuboidal ones with quite visible cell membranes. And we have lots and lots of vessels, the vasorector, which we can pick out because they have red cells in them. Okay, so that's normal histology of the cortex and medulla. Now I'll focus on the glomeruli themselves. I've picked silver stains to look at normal histology of the glomerulus because it shows us those basement membranes so nicely. I'll start with this image here. Here we've got the vascular pole. So this is where the arterioles enter and exit the glomerulus. And within the urinary space, we have the glomerular tuft, and that is made up of the mesangium, which contains matrix, and mesangial cells, which produce that matrix. And adjacent to those, we have the capillary loops. And these are made up of endothelial cells. We'll be able to see occasional endothelial cell nuclei, like that one. We can't appreciate the cytoplasm because it's so thin. The basement membrane lies underneath that, and that's what we can see staining here is this very thin black line. And over the surface of that, we'll have the podocyte cytoplasm. Again, that's inconspicuous because it's so thin, but we can pick out occasional podocyte nuclei if we look very hard. You can see one there, for example, and they're just nuclei sat on the top of capillary loops. But as I said, cytoplasm's not visible, just the nucleus. And then this glomerulus here, again, it's a normal one. It's just to show you the opposite pole. So this is the beginning of the proximal tubule. So this is where the urinary space is draining into. So that is what we call the tubular pole. So we have the vascular pole at one side, the tubular pole at the other, and the urinary space and capsule filled with the glomerular tuft made up of mesangium and capillary walls. So that's the normal. And now I'll go through the various patterns of injury that we get in renal pathology. So patterns of injury include normal. We can get subepithelial deposits. We can get endocapillary hypercellularity, mesangial hypercellularity, or extracapillary hypercellularity. We can get mesangial matrix expansion. We can get what we call membranoproliferative glomerulonephritis or mesangiocapillary glomerulonephritis. That they both mean exactly the same thing. Or we can get segmental sclerosis. And the appearances and the differential differs according to which pattern of injury you can put the biopsy into. So I'll run through those now. So the normal pattern of injury where you can't really detect any abnormalities at all. So the differential for this, obviously it could actually be normal. Minimal change nephropathy would look like this. A thin basement membrane disease also looks like this. Both of these, if you were to do electron microscopy, you would be able to pick up abnormalities. So in minimal change disease, you get lots of foot growth effacement, whereas in thin basement membrane disease, you get a diffuse thinning of the glomerular basement membrane. FSGS, focal segmental glomerulosclerosis, the ability to pick that up, because it's focal, so it only affects some glomeruli, not all of them, the ability to pick that up depends on the size of the biopsy, so how many glomeruli you've got. So the reliability of diagnosis of FSGS depends on the number of glomeruli you can assess. So if you've only got a few glomeruli, ruling out FSGS is going to be very, very difficult. So if you have a normal looking biopsy, but you've only got 3 glomeruli, the possibility of unsampled FSGS remains. Whereas if you've got a biopsy with 50 glomeruli in it, ruling out FSGS becomes a lot more certain. There's the potential diagnosis of C1q nephropathy, although depending who you talk to, some people may say that's not a disease and the pathogenesis is yet to be determined. So I'm not certain of that one, but some people would include that. Lupus nephropathy, lupus can look like anything in the kidney. So I would always include lupus nephropathy of some form in every diagnosis, every differential diagnosis in a renal biopsy. Alport syndrome, again, one that EM is useful for. So it could be one that looks normal on the light microscopy. And early glomerulopathies, for example, IgA with minimal changes could look normal. And then the rest of your immunostains, etc., and your EM would help you to narrow down your differential and hopefully pick one of these for your diagnosis. Just to show you some normal EM while we're having a look. So what we've got here, it takes a bit of getting used to, but once you've got it, EM is very nice to look at. You have a bit of mesangium here and another bit here where these capillary loops coming together, and this is sort of like this, the middle of a flower, and the capillary loops are like the petals surrounding that mesangial matrix. And this is the glomerular basement membrane, which goes right the way around the capillary loops and over the top of the mesangial matrix. So we can see that glomerular basement membrane there. And here we have endothelial cell nuclei, here, here, and here. And you can see that fenestrated, very, very thin endothelial cell cytoplasm going round the capillary loop and forming part of that filtration barrier. And on the other side of the basement membrane, this is the podocyte. So here we have a bit of podocyte nucleus and a bit of a cell body. And these little bits here are the foot processes of the podocyte. And you can see there's lots of little feet with a tiny, tiny filtration gap in between them. So these are, this is what normal podocyte foot processes look like. And here we have an even closer look. This is the edge of a red blood cell here, and this is inside the capillary loop. This is outside the capillary loop. So what we've got here is the endothelium. Here's the basement membrane, and here are the podocytes, the podocyte foot processes. There's the little filtration gap. And we've got some measurements here. So it's good to do measurements of the glomerular basement membrane if possible. As a rough rule of thumb, if you can find a normal foot process, for example, this one, the thickness of the GBM, the glomerular basement membrane, should be about equivalent to a foot process. So that seems to be the case here. And these measurements are all sort of within normal range. Sort of somewhere between 200 and 400 is about right for an adult. It differs according to age in childhood, and it will differ a bit from lab to lab as well, depending on the processing of the sample. So each lab will have its own normal range, but that's a rough guide would be 200 to 400. I think we can skip that one in the interest of time. So that was normal. Now subepithelial deposits, not many differentials for this one. Most cases will be membranous glomerulopathy, but lupus can also look like this, and occasionally amyloid could also look like this. And here I have a silver stain, and if you look very carefully at the capillary walls here, you can see they don't look smooth and very crisp. They look a little bit fluffy or a little bit indistinct, and when we look very closely we can see little spikes, at least in places. I know they're not visible everywhere. Over here is pretty good, and where it's cross-cut, like here and here and over here, it looks like it's full of little holes or lucencies. And that is what we see when there are numerous subepithelial deposits. When you have a biopsy that looks like this and all glomeruli are affected, and it's a diffuse process affecting every capillary loop, the diagnosis is almost always going to be membranous. If there are other changes going on, for example, if there are areas of proliferation, so there's hypercellularity as well, then lupus nephritis comes into your differential. And if you have this sort of appearance, but it's there in places, it's not everywhere, then you might want to think of amyloidosis, and obviously other stains like your Congo red in this scenario would be very helpful. And this is what they look like under the electron microscope. This is what typical membranous looks like. And here we have our subepithelial electron dense deposits. And what we're appreciating on the silver stain is the basement membrane. That's what we're staining. The deposits don't stain on the silver stain, the basement membrane does. So it's these areas of basement membrane that are extending upwards and trying to grow around these deposits. That's what we're seeing as spikes and holes and irregularities on the silver stain. So it's the reaction of the basement membrane that we can pick up. And when we do our immunostains, that will stain these deposits according to what immunoglobulin is being deposited in there. So that's typical of membranous. I've included this image of some slightly different looking subepithelial deposits just so that you can compare the two directly next to one another. You can see with these deposits, they look like they're sort of sat within the basement membrane, and you have this reaction around them. Whereas these deposits, they look like they're just sat on the top. They're not within the basement membrane down here. They're just sat on top, and there's no reaction to them at all. The basement membrane looks normal, but there's a deposit plonked on top. So these are what we call subepithelial hump-shaped deposits. And these are not the sort of things you would see in any of our differentials for subepithelial deposits. They're not what we see in membranous. These are what we see in post-infectious glomerulonephritis or C3, GN, those sorts of diseases. I just thought I'd put it in here because they're both subepithelial deposits. They're just of different types. And just to say, we can say that these are subepithelial because the deposit is touching the podocyte. So it's on the subepithelial side of the basement membrane. Subendothelial deposits, which are the other option for capillary wall deposits, would be touching the endothelial cell, which is here. So here we have basement membrane touching the endothelial cell and the deposit touching the podocyte. So it's next to the epithelial cell, not the endothelial cell. That's why it's a subepithelial deposit rather than a subendothelial deposit. Okay, and I'll show you some of those a little bit later. So our next pattern of injury, endocapillary hypercellularity. So there's a fairly large differential for this one. IgA is probably the commonest, but also lupus nephritis, particularly when it's what we call exudative, when it's full of neutrophils, like this image here, then we would particularly consider post-infectious or infection-associated glomerulonephritis. Also things like cryoglobulinemia, C3 glomerulopathy, HIV, immune complex-related kidney disease, HIVIC, and PGNMID, so a monoclonal form of immune complex deposition, proliferative glomerulopathy with monoclonal immunoglobulin deposition. That's what PGNMID stands for. Can all have this endocapillary hypercellularity appearance. So here we have an example on a H&E of endocapillary hypercellularity. And it's all neutrophils within capillary loops. That's what the abnormality is here. I think the easiest way to pick up endocapillary hypercellularity is to look for the capillary lumens. And if you can't see them, there's cells in there. So it looks really cellular. I can't see the capillary loops. Therefore, these cells are sat within the capillary loops. If you're having lots of difficulty deciding where a cell was, then other stains like the silver that show you the matrix versus capillary loop a little more clearly can also help. But in this case, it's straightforward and we don't need any help. We can see very clearly that these neutrophils are sat inside capillary loops. And we can also pick that up on EM. Here's an image of a neutrophil sat inside a capillary loop. Not one that EM is needed for, but can be helpful. Okay, and mesangial hypercellularity. So here there's an excess of cells, but they are sat within the mesangial matrix rather than inside the capillary loops. And this is another example of that. So here we can see the capillary loops if we look very carefully, and they look patent, they look empty. Whereas there are lots and lots of cells in here, we can see lots of nuclei, and they are sat within that mesangial matrix, this sort of pinkish stuff between the capillary loops. So that's why I can call this mesangial hypercellularity, or mesangial proliferation, means exactly the same. And these are our differentials. So not a huge list, but IgA nephropathy is the cause of many of these cases. Again, lupus nephritis, post-infectious or infection-associated, particularly if it's sampled a little later in the disease process, the endocapillary hypercellularity can disappear and be replaced by this mesangial cellular reaction instead. So that is in the differential. And again, that monoclonal form, the PGNMID, can also have this appearance. And here we have an example on EM, and the nuclei are quite easy to spot. There's 1, 2, 3, 4, 5 in that mesangial area there. This sort of palish stuff is the mesangial matrix, so that's all collagen. The slightly darker bit, this is the cell cytoplasm. And then these more variegated areas are the nuclei. And then over here we have the edge of a capillary loop, but we're focused on mesangium here. So we can see that cellularity. Okay, and then we have extracapillary hypercellularity, or crescentic GN. So there's 3 main differentials really. It can either be associated with vasculitis, it can be immune complex mediated, or it can be sort of other, which is generally sort of endothelial cell injury of some form or another. Most will fall into one of these first 2 categories. So vasculitis generally is either ANCA-mediated or anti-GBM disease. And if there is immune complex deposition, then there are quite a list, but the commonest ones would be that it's a vasculitic form of IgA, it's a form of lupus nephritis, it's an MPGN, membranoproliferative glomerulonephritis, or it's a post-infectious glomerulonephritis. But it's important to remember that the reason we get this extracapillary hypercellularity is because there's been rupture of a cell wall, of a capillary wall. So one of these capillary walls has burst, leading to extravasation of serum into the urinary space. When all of those proteins hit the parietal epithelial cells, which line the capsule here, that causes an inflammatory reaction and a proliferation of these cells. And that's what we're seeing here. So it's proliferation of parietal epithelial cells as a reaction to plasma proteins. And you can see in this example here a very large cellular crescent, and you can see that there's inflammation. We've got inflammatory cells and blood here, and we've also got a little bit of fibrin deposition. So this is clearly a very fresh lesion. This has happened within the last day or so prior to biopsy, because we still have fibrin, blood and inflammation there, as well as this cellular reaction. So because the reason why these forms is due to rupture of a capillary wall, it can be seen in pretty much any disease that causes that. So if you see one crescent in a diabetic, for example, you should certainly explore other options, but it doesn't necessarily mean that they've got a crescentic GN. I hope that makes sense. But these would be the common causes of a crescentic GN, particularly when this is the dominant abnormality that you're seeing. And this is what it looks like on EM. So it's a proliferation of cells with their nuclei in the urinary space. This is the capsule here. And then here we have the glomerular basement membrane, which is very, very wrinkled and corrugated and compressed by all of these cells outside in the urinary space. Okay, the next pattern of injury is mesangial expansion. So the vast majority of these, at least in my practice, are diabetic, but also monoclonal immunoglobulin deposition disease, amyloidosis, idiopathic forms, and occasionally advanced MPGN can have this sort of appearance. This is an example of a diabetic, and this is the nodular glomerulosclerosis that is classically described in diabetic nephropathy. So you can see these very large acellular areas of mesangial matrix expansion with preservation of capillary loops. And these are thought to form due to repeated endothelial cell injury, so that microvascular injury that occurs within a capillary loop and then is responded to by laying down of collagenous tissue. And as repeated insults occur, these areas get bigger and bigger and eventually form these nodules that we can see. So that's why we get this morphology in diabetes. That's probably also why we get it in idiopathic forms, which are generally seen in non-diabetic hypertensives or smokers, but this is a very unusual diagnosis, and it's a diagnosis of exclusion. So we have to exclude these other options before we can consider the idiopathic form. I think I've only seen that once, whereas these I've seen many, many times. Differing between these, obviously, lots of people are diabetic. Not all of diabetics have diabetic kidney disease, but many do. When you get a diabetic kidney, it's important to look for other things because often diabetic kidneys commonly have a second diagnosis in them. So it's important to look for those. Monoclonal immunoglobulin deposition disease could have this appearance, but the key would be if you look at your immunostains, particularly for light chains, there should be light chain restrictions, so one staining much, much more than the other. Amyloidosis, again, looks like this, but your Congo red will sort that out. Advanced MPGN could have this appearance in the mesangium, but you'd still have those capillary wall changes, so you'd have reduplication of capillary walls that you wouldn't see in a pure nodular glomerulosclerosis. And here I've got an example of the EM for you, and this is an example of amyloidosis. So here we have that mesangial nodule, has a slightly fuzzy look to it, and then when we look at very, very high power, you can see it's formed of all of these tiny fibrils, and the measurements are sort of 8 to 12 nanometers in dimension, and that's consistent with amyloid. So that's an example of amyloidosis. And just for comparison, this is an example of diabetes. And here again, we have that sort of mesangial expansion with sort of nodules within it, but with no substructure that we can see. So this is just collagenous scarring rather than anything else. Okay, and then MPGN, probably the most complex of the patterns that we've discussed today. So there are two things going on that we need to see to call it MPGN, membranoproliferative glomerulonephritis. We need proliferation within the mesangium. You can see that here. We've got lots and lots of cells here. We also need reduplication of capillary walls. And you can see that, for example, here. So capillary walls look very, very thick. And when we look at other stains, we'll be able to see that there are 2 layers of basement membrane rather than 1. Also in this one, we do have a bit of endocapillary hypercellularity, for example, here. So often there's a bit of a mix of all of these patterns. And when you get a mixture, try to pick a dominant pattern and go with that when you're thinking about your differentials. So differentials for the MPGN pattern. So your sort of classic MPGN would be either immune complex mediated, or we're thinking of the sort of C3 GN area, which is either dense deposit disease or C3 glomerulonephritis, and those are differentiated by electron microscopy. A chronic TMA, thrombotic microangiopathy, has this appearance. Lupus nephritis, cryoglobulinemia, PGN-MID, can all look like this and are often quite cellular. And there are lots of secondary causes that can look like this. So infections can cause this. Even sickle cell nephropathy can have its appearance as well. And here we have an example of the EM with very large subendothelial deposits. This is from a case of lupus nephritis. And here we have the deposit. So this very dark grey material that is sat underneath the endothelial cell, which we can see here. So it's adjacent to the endothelial cell. So this deposit is lying in between the endothelial cell and the basement membrane. So it's a subendothelial deposit. And then on the outside of the loop, we have the podocyte. So that's a very large subendothelial deposit in a case of lupus nephritis. And here we have another example of basement membrane reduplication. In this case, not due to deposits, but due to mesangial cell interpositioning. Here we have an example of a mesangial cell with its nucleus. You can see it's put sort of arms of cytoplasm around the capillary loop. Oops, sorry, just go back. And you can see that to either side of this capillary loop. And we have our original basement membrane here, adjacent to the podocyte, but we have a new layer of basement membrane here, adjacent to the endothelium that's being laid down as it attempts to repair the filtration barrier. But whatever's caused this mesangial cell to react like this is not apparent. So this could be what you see either in a later sampling where any deposit has been resolved, or it can occur in a case where there is no immune complex deposition and it's a case where there's endothelial cell injury. So, for example, sickle cell nephropathy might have this appearance to it. One more EM image of this. So this is what we see in acute endothelial cell injury. Again, we have the endothelial cell here. This is the inside of the capillary loop with the red cells within it. Here we have the endothelium. Then we have a large space, and then we have the basement membrane, and then the podocyte. So this is what we call subendothelial lucency. So all of this widening of the subendothelial space is a reaction to damage to the endothelium. And you can see here there's even a red cell that's managed to escape out of the lumen into this subendothelial space. So clearly the filtration barrier is not working properly here. So that's another example of a case where you could see an MPGN pattern. And that's something you could see, for example, in a TMA, a thrombotic microangiopathy. Okay, and then segmental sclerosis. So this is both a diagnosis and a pattern of injury. So FSGS, focal segmental glomerulosclerosis, can be primary. These people are generally nephrotic, or it can be secondary, and these people are not nephrotic but may have nephrotic range proteinuria. The differential for this pattern is very, very wide. Pretty much any glomerular disease can give you segmental sclerosis. In the absence of any other features, any other abnormalities that you can detect, and in the correct clinical context, so in the context of the nephrotic syndrome, a diagnosis of primary FSGS could be made. Also to diagnose secondary FSGS, for example, people with obesity-related glomerulopathy. So any form of hyperfiltration injury will give you this pattern of injury, so obesity, hypertension, people who take huge amounts of protein supplementation, all of those sorts of people could end up with this sort of injury, and that would be a form of secondary FSGS. But the large caveat for this is any glomerular disease can give you this lesion. So cases of lupus nephritis will often have these lesions. IgA nephropathy will have these lesions, and that's because it's a form of scar. So it's not a specific diagnostic lesion. It's only diagnostic in the correct clinical context. It's a very, very non-specific lesion to see. And here we have an example on electron microscopy. So we're looking at relatively low power for electron microscopy here. We've got the capsule around the outside, and here's the glomerular tuft. Here's the urinary space. There's a podocyte. And here we have the basement membrane going around the outside. It's quite difficult to see a lot of capillary loops, but we can see a few, particularly around the periphery, but much of the middle of this glomerulus is all replaced by this pale grey material, and this is your FSGS. So it's all collagen scar that is replacing your normal architecture. So that's segmental sclerosis on electron microscopy. Obviously, I haven't covered everything. There are lots of other lesions that you can see. I'll just quickly run through a few of those. Here we have foamy podocytes that you'd see in sort of lipid disorders like Fabry's disease. This is an example of a collapsing GN, so a form of FSGS where the glomerular tuft is very, very contracted. Capillary loops are almost invisible because they're so small, and there's marked podocyte proliferation. That's an example of collapsing FSGS. And that's what you would see in HIVAN, HIV-associated nephropathy. Here we have an example of a relatively normal glomerulus, but with fibrin thrombi within capillary loops. So that's just to show you what fibrin thrombi look like in the kidney. Both of these are showing very similar lesions. Both of these are forms of FSGS. Here we have what we call a tip lesion, and that is FSGS that's occurring at or very near to the tubular pole. So here's the beginning of the proximal tubule, and the glomerular tuft appears to be stuck to it and has some endocapillary foam cells at that point, and that's what we see in a tip lesion. So that's a variant of FSGS. Here we have another variant of FSGS. This is cellular FSGS. I just thought I'd quickly show you these because they don't look like your typical FSGS because they look quite cellular. They don't have that sclerosis, and both of these are probably early forms of FSGS. So presumably the sclerosis hasn't had time to develop yet. But if you were to biopsy these people again later down the line without treatment, sclerosis would develop. But here we've got endocapillary foam cells. So that's what we call cellular FSGS. And this one, not a glomerulus at all, it's a granuloma. So just a reminder, obviously we're focusing on glomeruli today just in the interest of time, but there are obviously interesting and important things to see in the tubules, the interstitium and the vessels as well, and that's just one example of something you might see. So granuloma, you'd think of granulomatous tubulointerstitial nephritis, of which there are many causes, drugs and infections being the main ones. A few other things. Here I have an example of cortical necrosis. So we've got a glomerulus here, and we've got lots of tubules here. And the structure's still there, but all of the nuclear detail is pretty much gone. So I can't see any tubular nuclei here. There's maybe one or two there, but generally they're gone. So that's not going to recover. And the same in this glomerulus here. The structure's still there, but all of the nuclei are gone. So this is irreversible cortical necrosis. Here we have an example of casts. Just to show you, inside tubules, you can get all sorts of different casts. This is an example of myoglobin cast nephropathy. So these very reddish, granular looking casts. So this person will have had rhabdomyolysis of whatever reason, leading to myoglobin cast nephropathy. So that should be recoverable with supportive treatment. And here we have an example of scarring. So we have an obsolete glomerulus, so it's a globally sclerosed glomerulus. No functioning capillary loops are visible there at all. It's all been replaced by collagen, so it's just a complete scar. The tubules are still here, but they're very, very tiny. These are atrophic tubules, and you can see this is the tubular basement membrane. It's very, very thick. And this is the commonest form of tubular atrophy that we see in the kidney. So very tiny tubules with very thick basement membranes, and there's interstitial fibrosis. So the interstitium is much more visible than it normally would be, running in between these tubules. So that's also scarred and increased in volume compared to normal. Okay, and just one more thing I thought I'd show you on the electron microscopy before we move on to cases. This is what a tubulo-reticular inclusion looks like. So we're looking at an endothelial cell here. You can see it's got that fenestrated cytoplasm that we've talked about. Here's the basement membrane. Here's podocyte foot processes. There's actually a little deposit there as well. This is from a case of lupus nephritis, so we've got some subepithelial deposits up there, and we've got this tubulo-reticular inclusion in the endothelial cell here, which doesn't tell us definitely this patient has lupus nephritis. It's thought to be some form of interferon gamma deposit, so it can be seen in other things as well, particularly in people who are receiving interferon therapy. But the most common reason we see it in the kidney is in patients with active lupus nephritis. So it's not diagnostic, but it's a supportive feature if it's there in the correct clinical context. Okay, so a couple of example cases, and then these should be quite quick, and then I'll take any questions. So a 73-year-old man presented with renal impairment, hematuria, and proteinuria. So putting that together, I'm implying that this person has CKD, chronic kidney disease, and they'll have hematuria and proteinuria secondary to that. So CKD is my differential. So you can remember there was quite a long list of CKD differentials. So think about those, and I'll talk you through the images. So here we've got our H&E. We're focusing on a glomerulus, and it maybe looks like there's a little bit too much matrix, but it's not that easy to see. It doesn't look obviously abnormal. It's relatively normal. Can't see much in the way of proliferation. So let's have a look on our other stains. On our PAS and our silver, the mesangial matrix is fairly prominent. Obviously, this just takes a lot of practice to get into your head what normal looks like and to have that very firmly known so that you can say when there are abnormalities there. So that's just something that comes with practice. But here, the mesangium is increased in volume. So Congo red's a useful stain to have because amyloid is one of our differentials and it's negative. So it's not amyloid deposition. Immunostains have been done, and here we've got our light chains. We've got kappa and lambda. And these are very difficult stains to do and very difficult stains to interpret. But here we can see that the kappa looks a little bit darker than the lambda. So it suggests that there's kappa restriction in these increased mesangial areas. So putting all of that together, obviously I would want to seek more clinical history, but putting it all together, I would say that looks like MIDD, monoclonal immunoglobulin deposition disease. In this case, the patient didn't have a known plasma cell dyscrasia, so they didn't have myeloma or anything close to it. So this was called MGRS, monoclonal gammopathy of renal significance. So sort of a disease that looks like it's myeloma associated, but without the myeloma being obvious. And this person will be monitored and they may develop a plasma cell abnormality in the future. Okay. Just one more case to look at. So this is a 25-year-old female with increasing proteinuria and low complement levels. I'm sure there was more clinical history, but I don't want to give the game away. So here we have a glomerulus. Most of it looks pretty normal actually, but we've got an abnormal area over here where we've got certainly too many cells in this segment of the glomerulus. Some of those cells seem to be sat in the urinary space. So all of these, I would say, are in the urinary space. So that's a cellular crescent. Also, the glomerulus adjacent to that area shows some endocapillary hypercellularity, and lots of that is karyorectic. So there's lots of cellular necrosis going on here. So presumably one of the capillary walls in this area has ruptured, leading to the formation of this cellular crescent. So we've got endocapillary proliferation and a cellular crescent. And here we have our silver stain, and this is also abnormal. And we can see lots and lots of spikes on this glomerulus and lucencies in the cross-cut areas of basement membrane. Here we've got more spikes, again here and up here. Every capillary loop is showing the same sort of thing. So we have a membranous pattern with some proliferative changes. And here we have some examples of some immunostains. I haven't labeled them because they all looked the same. They were all positive. So all of our immunoglobulins and complement stains all looked like this. So looking at immunostains, I haven't covered much today, but I can just talk you through this. So our mesangial areas in between capillary loops look like they're positive. They're staining brown, so that's positive. And the capillary loops where we saw those spikes, they're all staining as well. And similarly on this one, although this is staining a little bit less, we've still got mesangial positivity and we've still got capillary loop positivity. So we've got full house immunostaining. So all of our immunostains are positive. And here we have the EM for this young lady. And this is pretty low power. I think I've got some more images afterwards to show you, but here, these very dark regions, these are electron dense deposits. These ones are located in the mesangium. We've also got some of these similar sorts of things running around the capillary loop. And I'll show you a capillary loop in a little more detail. Here we are. So we've got a capillary loop here, and we can see there are lots and lots of subepithelial electron dense deposits. And one more image. Here we've got a tubulo-reticular inclusion. So putting all of those together, proliferative GN with some necrosis plus a membranous pattern with tubulo-reticular inclusions on EM and all of the immunostains positive. This is highly suggestive in this clinical context of lupus nephritis. There is a classification for lupus nephritis. We won't worry about that today. And this lady was found to have positive ANA and double-stranded DNA autoantibodies on her renal screen. So all of that fits together with lupus nephritis. Okay, so I'll stop talking there. That was a bit of a quick run through. I hope it was helpful. And I'll stop sharing my screen and take any questions. Thank you.